Okie dokie. So any questions regarding last lecture in particular? You know, everyone's an expert on it. I can test you all right now and you'd be set, right? Okay, so this is going to be the bugs and drugs lecture. It's what I call a little bit of a barn burner. So strap in. This will probably bleed over into the next lecture just because it is pretty lengthy. I'm mainly going to cover antibiotics. We're going to cover a little bit of a review about why we use antibiotics the way we do. And some special topics concerning that. And then we'll talk a little bit about antifungals and some antihelminthics towards the end. And then we'll cover antivirals a little bit later. So this won't be all-encompassing, but it covers most of it. So first section here is going to be the antibiotics. So have you guys covered gram stains at all? Yeah. You guys are familiar with gram stains. You know something, what that means to be gram positive or gram negative. So when I say something gram positive, what does that mean to you?
Got a thick peptidoglycan wall.
Yep, it's got a thick outer wall. It's able to take up that dye, and that's why it's gram positive, right? It's a positive stain there, right? So the grouping of the bacteria, this is going to be really important because we'll look at different antibiotics, and you'll see that we kind of differentiate them based on do they have good gram positive activity, do they have good gram negative activity, and then we'll look at other things like anaerobic activity and then also coverage for atypical bacteria. But the main delineation here is going to be gram positive versus gram negative. Obviously, you can see the difference in how those look on a gram stain itself. Obviously, the one taking up the stain is going to be a little bit darker versus the more pinkish color of your gram negatives. So, going over common causative organisms, this is obviously not a all-inclusive list, but these are some of the big ones you're going to be seeing out there in clinical practice. The big things you're going to want to be covering for when you are treating someone with an antibiotic. So, starting off with your gram-positive cocci, with the coagulase positive staphylococci, this is going to have your Staphylococcus aureus. Staph aureus, so then that's going to differentiate into either MSSA or MRSA. Does anyone know what that means? Yep, so methicillin susceptible Staph aureus or methicillin resistant Staph aureus. And so what is methicillin? Probably an antibiotic, right? So methicillin is an old school antibiotic. You won't really see it used anymore, but we use it for that naming convention. So if you hear of MSSA or MRSA, that's what that's in reference to. Does anyone know what VRSA is? Anyone ever heard of that term? Yeah, it's vancomycin resistant Staph aureus. That's going to be a really nasty bug that's really resistant to a lot of antibiotics. We'll talk more about that when we get to it. But again, this is just another delineation for the type of MRSA we're going to be dealing with. There's also a couple different strains of MRSA, so you can certainly have the community-acquired, you can have hospital-acquired MRSA, and so those are going to have different resistances to different antibiotics based on where they're coming from. So if you had to guess which one is probably more resistant, would you expect the community one or the hospital one to be more resistant? The hospital, obviously, hospitals are gross places. They're definitely not a place to actually get better in a lot of cases, especially if they're there for long periods of time. You're more likely to get more nosocomial bugs. They're highly resistant, especially if you hang out in the ICU too long. We then have your coagulase negative staph, so it's going to be your staph epidermidis. Where do you find that? On the skin. That kind of makes sense. It's on your epidermis. Then you have your streptococci. So you have strep pneumo is going to be the main one we're going to be focusing on there. I'm going to talk about some other ones as well. And then you also have your enterococci. So that's your ephasium and your eficalis. We'll talk about certain. Where do you think those normally end up? In the gut, right? Enterococcus. That kind of makes sense. Those are going to have specific coverages. Certain antibiotics may cover them. Certain ones may not. So that's one of the ones to we'll kind of look at a little bit. We then have your gram-positive anaerobes, and so these are important because in a lot of cases, things that work against gram-positive aerobic bacteria don't necessarily work against gram-positive anaerobic bacteria. So it's really important to delineate whether or not your antibiotic you're talking about has coverage for anaerobes. And a lot of them do not have coverage for anaerobes, and you need to know when you might suspect anaerobic infection versus not, right? So looking at the gram-positive anaerobic cocci, you have your streptococcus and your peptococcus. Where do you find those typically? Potentially in the belly, usually in the mouth. You have a lot of anaerobic bacteria in your mouth that grow there, so you'll find some of them there. You also have some of the bacilli, so you have Clostridium difficile. Does anyone know what that causes? Lots of diarrhea, C. diff, right? You can smell it a mile away. Then you also have Clostridium perfringens, just another variety of that. So we'll talk about C. diff as well, and which antibiotics have specific coverage for that, because that actually has some kind of unique ways to treat that. Yes?
If these are anaerobes, was the previous slide all aerobes?
Those are aerobe. Yeah, so unless I say anaerobic specifically, just assume I meant that they're aerobes. Yep. Because the majority of things you'll be treating are going to be aerobic bacteria, but the anaerobes will warrant special mention. Yep. Then you have your gram-negative bacilli. So this is a pretty wide-ranging group. So if you have your Enterobacteriaceae, the ones I have in red here are special note, which I'll mention in a second. But you have your common organisms, things like E. coli, Klebsiella, Serratia, Proteus. You also have some of the more nasty guys, really nasty causative organisms, so things like Pseudomonas aeruginosa. That's going to be a really important one because certain antibiotics have coverage for Pseudomonas, and I'll probably make big notes of that, and it's probably good to know for, like, I don't know, testing purposes. You also have other things that are really, you may only find in more immunocompromised patients or more chronically ill patients. So things like Stenotrophomonas, you may find mainly in things like CF patients who have kind of chronic immunocompromisation, they're chronically ill. And then Acinetobacter is another really bad one you'll see in a lot of cases where you have nosocomial pneumonias, like in the ICU. Patients will be on a ventilator for a period of time, then I'm getting a secondary pneumonia that is caused by Acinetobacter that's really highly resistant. Other things we'll talk about in this category include things like Haemophilus influenza, Moraxella. Those are pretty bad for causing things like pneumonias and whatnot. So we'll learn which antibiotics treat those. Obviously, you have your Neisseria species, and then for the anaerobics here, the big one we'll focus on is going to be our Bacteroides fragilis. So that's mainly the main gram-negative anaerobe that we'll talk about for these purposes. Now, when I say space pathogens or escape pathogens, these are ones that are in red. Does anyone know why these ones are of particular note? I hear resistance. Yes. So these are more likely to develop a lot of highly resistant strains where they will basically not be treated by the majority of the antibiotics we have available to us. So when they talk about like superbugs that we don't have any drugs for, they usually are referring to either these guys or some strains of things like Staph aureus. So things that have coverage against these are going to be really important because especially when you get to more of the multi-drug resistant ones. And we'll talk about some of those mechanisms for resistance and how we can overcome that. But these are going to be the more difficult to treat gram-negative bacteria that we'll talk about. And then you have some atypical pathogens. You see these a lot in some lower respiratory infections. Certainly have things like chlamydia, Legionella, and the mycoplasma as well are going to be included on this list. We'll talk about specific antibiotics that will have coverage against atypicals, and those would be other things that would be good to know for like testing purposes to know that an antibiotic has atypical coverage. So what's really important in when you are working out in the clinical world and you have a patient who comes to you with an infection, the most often way you're going to be approaching that patient is you say, okay, well, you have a skin and soft tissue infection, or you have meningitis, or you have osteomyelitis. And based on that, you're going to have a general idea of what the causative organisms are most likely to be. Because again, most of your patients are going to fall into, that's why these are, common things are common, so to speak. And so most of your patients, when they come in with one of these infections, are typically going to have one of these type of bugs. Now, you may have some atypical patients who, say, are immunocompromised, or maybe they are on chronic antibiotics, and so they may be selecting out for different types of bacteria. But in general, you can kind of get a feel for what the most likely causative organisms are going to be. So say, for instance, if you're looking at the skin and soft tissue, what do you notice about that group of bacteria? Mostly gram-positive, right? Because again, what lives on your skin most likely? What type of bacteria? We talked about Staph epidermidis. You have a lot of Staph aureus that grows on there. So because there's a lot of gram-positive bugs that are just growing on your skin all the time, when you have a skin infection, it's most likely going to be caused by one of those organisms, right? Same thing when you look at bone and joint infections. Typically, you're going to be seeing a lot of staph, a lot of staph epi, streptococcus, and then you might get into some other type organisms, depending on what the conditions are. So, a patient who has some kind of penetrating injury or some kind of crush injury may be more at risk for a certain type of bacteria than a patient who developed this in a different manner. So sometimes you'll see gram-negative rods and bone and joint infections, but it just depends on the type of patient. And we'll get more into that when we get to specific indications for these. This is just kind of a broad overview for this stuff. Meningitis, you see that, with the major causative organisms here. Notice here that you're going to be covering for some gram-positives, things like strep pneumo, and then the majority of the other coverage is going to be for gram-negative coverage, right? So you'll notice that some sites of infection are more likely to have kind of a mixed bag, and we'll have to use antibiotics that are going to be able to treat both of those type of organisms, right? Because whenever we can, we want to use one antibiotic, and we'll see why using 2 or more for the same coverage can be a problem. Looking at things like the abdomen, what type of bacteria does this look like? A lot of gram-negative coverage here, right? Because again, your gut, a lot of anaerobic bacteria are there, a lot of gram-negatives are there. This is where you see things like E. coli and Proteus. This is where your Bacteroides is mainly going to be found too. And we just said that was a gram-negative anaerobic bacteria. So when you are covering for an abdominal infection, you're going to say, well, I probably want an antibiotic that's going to have mainly gram-negative coverage, and then we'll also end up covering for some anaerobes, things like Bacteroides, right? Looking at the urinary tract, you see here as well, you're going to have a lot of gram-negative bacteria that are mostly causing things like E. coli and Proteus. But notice as well, you can have some gram-positive causative organisms, things like staph. And so any situations where you can think of where you might end up having gram-positives pop up, like a different situation for a UTI. So imagine if you had a patient who had some sort of foreign body that was in the urinary tract. So imagine someone who had a catheter that was placed there that was long-term, dwelling in that space. Well, obviously, if you're entering things into the urinary tract, you can introduce new bacteria. And what's on the skin? Gram-positive. So this is where sometimes you can see gram-positive bugs show up in the urinary tract infections, right? So it's not super common, but knowing your patient and knowing what's going on with them can help lead to you looking at having a better idea of what the most likely organism is going to be. And then we said in the mouth, you see a lot of anaerobic bacteria here. So this is where you see the Peptococcus and Peptostreptococcus. You don't need to memorize these slides right now. When you talk about the individual, we talk about things like acute otitis media in the next class. Like that's when you're going to want to know what type of bacteria you're going to be covering for. This is really just more for illustrative purposes. And then the other major place that you're going to be treating a lot of infections is going to be the respiratory tract. And so looking at things like the upper respiratory tract versus lower respiratory tract, because really your lower respiratory tract should be pretty much a sterile environment for the most part. But when you do get infections there, you can start to see things like a lot of gram-negatives pop up. For patients who are, have chronic illnesses, who may be more likely, have long-term hospitalization or be in the healthcare world. This is where they can pop up these nosocomial respiratory tract infections. You can see things like MRSA pop up. You have more things like Pseudomonas, and this is where you get into more kind of more likely to see multi-drug resistant bacteria popping up in these nosocomial settings. So, has anyone heard of an antibiogram before? So this is a really important thing. If you go to work in a hospital, if you go to work out in the community, it's important to try to acquire an antibiogram if you can. So most EDs that are connected to hospitals and places like that should have an antibiogram. And even if you have an antibiogram from kind of a neighboring organization within your community, that's also going to be really helpful. And so essentially what this is doing, and I apologize if you can't see it super clear up here, but hopefully you have the slide in front of you, is that basically you're going to have all of your bacteria listed here on the left side, and then you have different antibiotics that are up on this upper row here. And so essentially what you're looking at is those numbers, is that over time as they collect cultures for these from different patients who are coming in with these infections, they're keeping record of all of that, and they're finding out what the susceptibilities are to these different organisms, to different antibiotics, right? So they're able to look at this and say like, well, if I look at something like Pseudomonas and I look at, let's see. So you see the number of isolates that they were able to take, so you know what kind of number of isolates they're actually looking at. And then you look over, say, something like ceftriaxone, you see that only 28% of isolates were susceptible to ceftriaxone. Well, that's not very good, right? I don't want a 28% chance of treating my patient that drug will actually kill that bug, right? You want something that has a much higher probability. So I might use something more like piperacillin, which has a 97% susceptibility rate. That's much better chances, right, for actually curing my patient or whatever ails them. So again, this is after they culture the bug from whatever site it is, and then they will use different susceptibility testing in order to figure out whether or not the bacteria will actually be killed by that drug. Yes?
Is piperacillin zoosin?
It's contained in zoosin. Yeah, we'll cover that one in a little bit.
Are these designed and developed by locality, by hospital? It says here the hospital's name is on it.
Yep. So this one usually is going to be by hospital. So say, for instance, this is actually a good example of this. So Nemours opened up in 2012, right? So when you open up a brand new hospital, guess what? You don't have any isolates, right? So you can't really come up with an antibiogram. However, we knew the patients that we were treating were going to be in the Orlando area, so we were able to sneakily get some antibiograms from places like Arnold Palmer Hospital, able to get some from Florida Hospital, their children's emergency department and inpatients, and we were able to use that data and say, well, this is probably going to be very close to the patients that we're going to be treating, so let's go off of this to begin with, right? So where you can see things like where, well, if I'm treating a skin soft tissue infection, should I be using Bacterium or should I be using clindamycin? And based on the resistance rates in your area, that answer might change. So if I'm here in Florida, one drug may be better, but if I go work out in, say, California, a different drug might be better based on the local resistance patterns. And this is going to change anywhere you go in the country. It's going to change if you go outside of the U.S. And this is why it's so important to have information like this so you can make more educated guesses on what the bug is most likely to be susceptible to. Because it takes time to culture a bug, to grow it out, to see what drugs it's susceptible to. You want to treat your patient right now, right? So this is giving you the best chances possible to get the right drug the first time. Does that make sense? Okay. So getting, how do we actually tell whether a drug is going to kill off a bacteria or not? You're going to cover this in microbiology for sure if you haven't covered it before. But this is different methods. This is certainly not exhaustive of looking to see what type of drugs a bacteria is going to be susceptible to. So basically on the left slide here, what are those different white dots, do you think? Those are different antibiotics. So basically you culture out the bacteria onto the plate and you put the different antibiotics there. And based on that circle, based on how far out that goes, you can see whether or not the bacteria is really going to be all that susceptible to the drug. And so if you imagine, do you want a bigger circle or a smaller circle? Probably want bigger, right? Because that means that as the disc diffuses, this is the disc diffusion test. As it diffuses out, you're going to see that the concentrations of the drug is going to drop. And so as the concentration drops, eventually you're going to get to a point where the bacteria can grow even in the presence of that drug, right? And so that's why when you have smaller circles, like the one in the upper right-hand corner, you'll see that one is probably more resistant to that drug because the bacteria is able to grow within a higher concentration of that drug being present. Right. A similar thing is happening over on this right slide here, where they have two different strips that are being placed down that are impregnated with different concentrations of that drug. And so as the concentration goes up, you see that circle of where the bacteria can't grow is getting bigger and bigger as the concentration gets higher. Does that make sense? So based on that, you can kind of tell what what concentrations you're going to be targeting are going to be within the body and whether or not that drug is going to be effective. So I can use a drug that a bacteria might be particularly resistant to, but if I get the concentration high enough, I can eventually kill it off. But what's that going to do to my patient?
Might be toxic.
They're probably going to get toxic, right? And so that's going to be no good. So I need, and we talked about this in pharmacodynamics, we need to really target for that therapeutic index where the drug is going to be efficacious and I'm not going to cause a whole lot of toxicity to the patient. And so this is what a lot of this information we're getting is going to tell us, is whether or not this drug is more likely to be used in a patient, is going to be successful based on what kind of concentrations we need to achieve with that.
I have a question.
Yes?
Would you do this with like cultures from your patient, or is this just a study?
Yep, so this would be with cultures from a patient. So you would actually, because again, different patients are going to have different strains potentially, so I would culture this out in the patient. You'd start them on empiric antibiotic therapy, and so that means we're, based on the patient coming in with, say, a pneumonia, I know that most likely organism is going to be X, Y, and Z, and I'm going to use this antibiotic to cover it. I don't know if it's actually going to kill that bacteria off, but this is what my best idea is. That's empiric coverage. I'm going to get the culture. And it's really important to do this before you start antibiotics, because what's that going to do if I do the culture afterwards? It's going to potentially kill off some of that bacteria, and I'm not going to get a really good idea of whether or not sometimes you'll pull out different strains once you have that selective pressure on there. So it's important to get these cultures done before you start antibiotics. It's really important for things like meningitis. It's really important for things like pneumonias. So you really always want to get your cultures beforehand. So by getting that, I'm treating them with empiric antibiotics. I have my culture that's cooking. This takes a couple days to come back. And then when these results come back, I can look at the results and see whether or not things are intermediate, resistant. It might come back and then the drug that I started is completely resistant. That means I now need to switch therapy, right? Any questions on that? Okay, so how do we control the emergence of resistance? It's a super important topic. This is the old way that we used to decide how to treat patients. You would basically say, okay, I'm going to do this drug and for this long. That's not really good, right? Because we're going to end up, if we play a guessing game, we're more likely to end up with either a patient who's not being treated appropriately or resistant bugs that are popping up. So we don't want to do this. We want to have very targeted methods for choosing what type of antibiotic we're going to use for how long. So why is this such a concern? Well, the more selective pressure we put on these bugs, especially when we're using things like broad spectrum antibiotics, which we'll talk about in a second, you're going to have emergent strains of these really highly resistant bugs starting to pop up. So things like MRSA is going to have a higher incidence. You're going to have a higher incidence of things like vancomycin-resistant Enterococcus, vancomycin-resistant Staph aureus. And then you also, with the gram negatives, these are especially nasty because we're having fewer and fewer drugs that can cover these. Some of the acronyms you'll see here is going to be extended spectrum beta-lactamases. We'll talk about what beta-lactamases are in just a minute if you don't know. But basically, these are new products that the gram negatives are coming up with that they're able to basically inactivate a larger number of beta-lactam antibiotics. We use beta-lactam antibiotics for a lot of different gram negatives, but as they start to have this extended spectrum beta-lactamase, fewer and fewer of them are going to be effective. And then you also have these Klebsiella producing carbapentamases. That's a mouthful. But basically, Klebsiella originally was producing these things that would basically inactivate carbapenems, which is going to be a group of antibiotics that we'll talk about a little bit later. And so carbapenems, as we'll talk about, they're kind of like gorilla cellular. They kind of kill everything. So if now we're having bacteria that inactivates those, that's a big deal. And if you're looking for the largest number of bacteria, or the group that kind of accounts for the most of these resistant infections, you're going to see Klebsiella, E. coli, Pseudomonas, and Acinetobacter. You guys remember seeing those previously? Mm-hmm. Those are space bugs, right? Or the escape is going to include the Klebsiella. So you'll see kind of two different names for that, but the escape bugs are included in that as well. This is why it's such a big deal. So what's going to be causing resistance? Why do we see this pop up? Lots of different reasons. One is going to be indiscriminate antimicrobial use. So if you really are in the habit of just using one drug for the same type of complaint every single time the patient comes in, that may not always be appropriate, especially as guidelines change. You'll see that certain antibiotics will go out of vogue. Certain new ones will come into the spotlight because the way that the resistance patterns are changing may make this antibiotic much better 10 years from now than it was, say, right now. Also, if you have inappropriate double coverage, and what does that mean? Yeah, so if I give 2 antibiotics for the same indication. Now, there are legitimate cases where you do want to double cover. We'll talk about that later. But in most cases, you want to use one antibiotic whenever possible. Because again, the more selective pressure you put on those bacteria, the more likely they are to develop those resistant strains, or they're going to pop up. And then also not de-escalating or streamlining therapy. So what does de-escalation of therapy mean to you?
Lower dosing.
Not lower dosing. Not necessarily. So when I say de-escalation of therapy, basically what that means is that normally when we talked about the empiric therapy, right? That's based on my best guess, based on guidelines, based on what most likely bacteria are going to be. I'm going to start off with this empiric therapy. Generally, you're going to see that the antibiotics I start for empiric therapy is pretty broad spectrum, right? That means they're going to kill lots of different bacteria. Now, when I get that culture back that says, okay, it's this bug and it's susceptible to this, that means I can de-escalate therapy and I can kind of laser focus my drug therapy to choose this one antibiotic that's going to cover this particular bug. So it's using much more targeted, narrow spectrum therapy to kill that one bug rather than trying to destroy everything, because that's when you're going to see resistance pop up. That's where you can see things like C. difficile colitis pop up as you kill off normal gut flora. All kinds of problems show up. So de-escalation of therapy is really important as well once you get those cultures back. And the streamlined therapy would be if I was double covering when it was appropriate, and then once I got the culture results back, I would DC one of the other drugs in favor for the one that I have right there, right? So using one drug whenever possible.
So de-escalation is good?
De-escalation is always a good thing, if you have the right data to support doing that.
When you say double covering, does that mean that they're prescribing the antibiotic at the same time, or is it like if a patient's diagnosed with otitis media and then 15 days later they get otitis media again and you give the same antibiotic?
Nope. Double covering would mean, and this is a good example when it would be appropriate to double cover. So say you have, you're working in the emergency department and you have a 90-year-old little old lady coming in from the nursing home, right? So those kind of patients are notorious for having all kinds of resistant bugs. And she comes in with pneumonia, right? So you get a chest x-ray, looks like pneumonia, you say, okay, I'm gonna treat this. Because of her history, because of where she's coming from, being in the nursing home, she's more likely to develop really resistant bugs. And okay, well, because she's in the setting, I know she's at risk for things like MRSA. I know she's at risk for things like Pseudomonas. I need multiple antibiotics to cover all of that for my empiric therapy to make sure I'm most likely targeting what she has. Right, so I would start off with things like I'm going to start vancomycin, and I'm going to start an aminoglycoside, and I'm going to start Penicillin, tazobactam, right, to cover all that stuff, right. And then when I get those culture results back, then I'm going to de-escalate therapy. I'm going to say, okay, now I can just stick with the aminoglycoside or whatever it happens to be. That makes sense? Yes.
What is empiric therapy again?
So empiric therapy is when you have a patient who comes in, say they're complaining, say they have an abscess, right. I know that based on my guidelines and based on what I know about the pathophysiology, I know that most likely they have X, Y, and Z bacteria they're growing. Staph, could be strep, could be any kind of, whatever it happens to be, whatever infection it happens to be, it could be, this is what I think is most likely causing it. I'm going to start empiric therapy with an antibiotic that's going to cover all that stuff, right? So empiric therapy is generally going to be very broad spectrum, and then as you get culture results back, you're going to go to more narrow spectrum coverage. So switching over to antibiotics that cover fewer bacteria and only have that laser focus on the one that actually did grow out. Yes?
With the de-escalating, do you just stop the empiric, or do you slowly reduce the dosage?
Nope. Nice thing with bacteria, with antibiotics is you don't have to ramp down the dose at all. You just stop it and you're done with it. Yep. And so sometimes when I'm de-escalating, say I start off with a 3-drug combination for that little lady that came in, and I get my culture results back, I may DC all 3 of those and start up another narrow spectrum one that is specifically going to be, the bacteria is specifically susceptible to that one antibiotic.
How compliant are your patients? I mean, your little old lady is going to have nursing care, but how compliant are your patients that show up in the ER that you just treat empirically, and then you say, okay, I've given you this prescription, you've gotten it filled, 2 days later I'm going to call and I'm going to give you a more narrow spectrum. I mean, do patients actually...
So what happens typically, and so I'm speaking, I haven't worked in an adult ED in a couple of years now, so I'll mostly speak from peds experience. So what would normally happen is that say you were to get, a lot of cases, especially things that are like kind of run-of-the-mill, like acute otitis media, things like strep pharyngitis, like most of the time you're going to treat with whatever the guidelines say as empiric therapy, and you're not really even going to culture it. Right, so there's some instances where you may not culture anything, where you're just not really that worried about it. You say, okay, this empiric coverage is probably going to cover it, it's fine. That little old lady who's probably going to be admitted to the medical ICU, absolutely you want to culture that, right? So sometimes what happens though is that say a patient comes in, you diagnose them with a UTI, you go ahead and get a culture prior to starting antibiotics while they're there, and so you send them off on empiric therapy, right? Someone starts cephalexin on them and send them off. A few days later, you might get those culture results back, and it says, hey, it's actually resistant to this, but it's susceptible to these other antibiotics. You would give them a call and phone in a new prescription for them for the proper antibiotic and let them start that. And then at that point, you start a new course of therapy. So how many ever days you're treating for, it'd be 7, 10, 14, that would restart at that point, right? Because previously you're using a kind of an antibiotic that didn't work for that. Any other questions? Okay. Other things that will cause resistance to pop up include if they have greater than 7 days on mechanical ventilation. And why do you think that might increase their risk for developing bacteria or an infection?
They can't cough anything out. They can't mechanically get rid of anything that's inside of them.
Their lymph isn't circulating either.
Yeah, so basically the thing is, and you're kind of all
Plus you
getting the
got
point.
Stuff in it, right?
Exactly. You have a big thing of plastic down your throat, that's just inviting bacteria to go in, right? So even though you do proper oral hygiene and things like that, you're still, a long enough period of time where you have this foreign body that's basically going down into your lungs, which should be a protected site, should be sterile. Eventually you're going to invite new bacteria in. Being in the medical ICU, this is where you see a lot of resistant bugs pop up. There's lots of antibiotic use. That's where you see more resistant bugs are going to pop up in those patients' lungs now, right? So, say you're treating your patient, say they were coming in for a non-infectious process, say they were a trauma patient, right? And they happen to be intubated for whatever reason, and they're there for 7 days, and all of a sudden they start spiking fevers, and their O2 stats start going down, and you check it out and say, oh, this actually looks like a pneumonia. That's when you're going to see, even though the patient was previously healthy and did not really come in for an infectious cause, now they have these really resistant bugs popping up, just because you might have, your unit might just have those bugs floating around, right? And there are cases where certain units of an ICU, they will have a super resistant bug that will pop up, and you'll have like several patients all catch it at the same time, and they have to move those patients to do a terminal clean of the entire unit just to try to get rid of it. It's a rare instance, but sometimes you'll actually see that happen where they close down the whole unit, move the patients out, clean up the whole thing, and then they can have patients move back in.
So these superbugs that float around, you said they're primarily in the ICU. They're not found as much in other departments like emergency or any other place?
It depends. So sometimes if you have like chronically ill patients who are coming into the ED, who are maybe on multiple courses of antibiotic therapy, or they're on it for chronic periods of time, sometimes they'll come popping up with it, or especially if they're coming from like nursing homes or other kind of like long-term medical care, you'll see them have a lot of resistant bugs, especially, if they have like, chronic indwelling catheters and things like that, they can develop a lot of resistant bugs. ICUs are huge for that, certainly. Usually on your med surg floors, you don't see that quite so much because those are generally healthier patients, and so they're less likely, they generally have more kind of competent immune systems and more likely to pop up with those kind of bugs. Not to say it couldn't happen, but it's just less likely.
So for the patients that are vented, like, is there possibly a way where you can like give them a break or like change out the tubing or something, or do they fully just get it?
Yep. So some people are just going to get it. Sometimes you can't really help that. Especially when you're critically ill, your immune system is not functioning really at the peak of its performance, and so you can end up seeing they're just more at risk for that, right? Sometimes you'll see, especially with certain really nasty gram-negative ones, it's kind of getting off topic, but you'll see really nasty gram-negative things like Pseudomonas. They actually produce this biofilm, and so sometimes your tubes actually will just get infested with this stuff, and it's basically just covered with these bacteria that you can't really get rid of, even if you're applying pretty copious amount of antibiotics systemically, because you're never going to get rid of the stuff that's on that tube, right? Because you're not really applying it directly to there. So yeah, they will change out the tube, and so certain places will have protocols so they change out the tube every so often, right? That's a very good question though. Okie dokie. So again, prolonged hospital stay is obviously going to increase your risk for infection because hospitals are very dirty places. And then prior antibiotic use. So especially if you were receiving multiple antibiotic courses for prophylaxis purposes. And again, what does prophylaxis mean? Yeah, as a preventative. So you're giving it to prevent an infection from happening in the first place. So, say you have a patient who has a heart valve that's been replaced, and they're more at risk for things like, getting endocarditis, and they need to go in for a dental procedure. Sometimes you'll see where we actually will give them antibiotics beforehand to keep them from getting an infection. So it'd be a prophylactic antibiotic. And then anytime you're using a really broad spectrum antimicrobial, you end up seeing that selective pressure being placed, and because you're killing off tons of different types of bacteria, you really select out for resistant ones, and then they can pop back up. So some of the ones we'll talk about, they're really broad spectrum. They're more likely to see this with include things like Piperacillin, Tazobactam, Cefepime, and then Meropenem. So you'll see those in just a little bit when we get to those. So what causes resistance as well? Certainly there's lots of antibiotics that go into a lot of the farm animals that we eventually consume, and I'm not advocating we don't eat animals, I'm totally down with that. But they do receive a lot of antibiotics just to keep them healthy, and so as we ingest that stuff, we're kind of getting exposed to that as well, and so that's thought to also lead to some degree of antibiotic resistance over time. Okay, so what are some different mechanisms in which you might see resistance pop up? What are some of the ways that these bacteria can become better at either inactivating or destroying the drugs that we have? Yes?
Plasmid sharing?
I'm sorry?
Sharing plasmid?
Oh, absolutely, yeah. So you'll see a lot of that. But some of the actual mechanisms for what they can do when they exchange those plasmids, like what are those plasmids telling the bacteria to do? So one of them could be things that prevent the antibiotic from actually getting into the bacteria to have their site of action. So if you look here at the upper left, you see this loss of porins. Sometimes porins are needed to allow the antibiotic to get to where it needs to go. If you cut those porins out, all of a sudden the antibiotic cannot get in. You can have things like overexpression of transmembrane efflux pumps. So those would be things that would pump or shuttle the antibiotic outside of the bacteria from the intracellular space to extracellular, so that way they cannot act at their site of action. And we talked about a bunch that already work intracellularly when we talked about ones that affect ribosomal function and the decreased protein production. Certainly you can have things that will bypass certain targets. So when we talked about things like our sulfonamides that worked against the production of or the processing of folic acid, sometimes they can find ways to actually bypass or circumvent that pathway to make it still effective, and they can still make their DNA. You'll see changes in proteins. So certainly if they were to change the structure of the protein enough to where the antibiotic can't actually bind to it anymore, then that could also lead to it being less effective. And then sometimes you'll actually have changes to where the bacteria start producing products that actually inactivate the antibiotics. When we talk about beta-lactamases, those are things that are actually destroying the antibiotic by inactivating them through a chemical means. So lots of different ways that these antibiotics or these bacteria can produce ways to circumvent our antibiotics that we're giving. And again, as you apply more and more selective pressure, you're going to get more strains that are doing all these different things. So even though you have a Klebsiella producing carbapenemase, you can still see those same things popping up in E. coli, or you can see it popping up in Pseudomonas, because they are exchanging these plasmids. So it doesn't have to necessarily come from a Klebsiella. But certainly when you get those culture results back, you'll see Pseudomonas aeruginosa growing, extended spectrum beta-lactamase producing, KPC producing, and those are big signs that, hey, we have a really resistant bug here. And that's all through that plasmid sharing. Any questions on that? All right. So what are some ways that we can help to prevent resistance from popping up? And a lot of times you'll see in hospitals that they have an antimicrobial stewardship program. And the whole idea behind that is to limit the amount of inappropriate antibiotic use, and also to do things to help prevent the emergence of resistance. So one of the things you can do that really helps with this includes formulary restriction. So saying that, okay, you can only get this antibiotic only if it's been approved by infectious disease if it's for this indication. So say, for instance, you have something like Penicillin tazobactam, which is otherwise known as Zosyn. Over at Nemours, that is a restricted antibiotic. We don't use that unless you have an ID attending who's approved its use for a specific indication, right? So you actually have to consult with ID and say, hey, can I use this? And they look at the patient, they're like, no, don't use that, use this other drug. So getting intensive disease, infectious disease involved is really helpful for that sort of thing. Antibiotic cycling would be a case where you would actually cycle out different agents within the same category in order to help limit the emergence of resistance to that particular drug. So say, for instance, you work in an ICU, use gentamicin as your aminoglycoside of choice. And then after, say, 6 months or a year or so, you switch out and then you start to use tobramycin instead. And then you switch out and use amikacin instead. So that way the bacteria never really get a chance to catch up and get resistant to that particular drug, and that helps to relieve some of that pressure. Obviously, treating for an appropriate duration of therapy is really important. So treating something too short for a period of time allows for the bacteria to come back, and that can be bad for your patient. But also treating for too long a period of time helps to lead to resistance. So in a lot of cases, when you're dealing with computerized physician order entry, or using things like Epic, I don't know if you guys ever heard of that. That's one of the big ones that we use. A lot of those antibiotics actually come with automatic stop dates on them. So say you can only get this one for 14 days, and after that it'll automatically fall off the patient's MAR. Okay, that helps to limit the overuse of some of these antibiotics. We talked about de-escalation. We talked about having one of the things you can also do is have specific antibiograms to different units. So if you know the medical ICU is going to be a big place for these to pop up, it doesn't make sense to look at med-surg patients when you're looking at your antibiogram, because those patients aren't going to have the same bacteria, the same spectra that your ICU patients will. So sometimes you'll see unit-specific antibiograms that are being developed. Also, lots of education. Looking at audits is helpful. Having rapid diagnostics in your micro lab is super useful. So the sooner you get culture results back, the sooner you can de-escalate therapy. So those are always helpful. Obviously, following your treatment guidelines. So that way you're making sure you're covering the right stuff without using things that are too broad spectrum. And then also looking at things like pharmacokinetic and dynamic dose optimization. So you guys remember back when we talked in pharmacodynamics about therapeutic drug monitoring? Wow, you guys already forgot that?
Yeah.
Therapeutic drug monitoring is super, super important. We'll talk more about that in this lecture. But essentially, making sure that we're getting our drugs to the appropriate levels to where they can actually kill off the bacteria without causing toxicity is really, really important. Because if I'm treating a patient subtherapeutically with an antibiotic, that's going to do nothing to treat the infection, and then it can also lead to more resistance. So therapeutic drug monitoring is going to be super, super important for certain classes of antibiotics. Okay, so moving on, any questions about any of that? Yes?
I want to hear what you said about the duration of antibiotic treatment and you said just stopping it.
Yep, so oftentimes, as you'll see when you get out into clinical practice, if you're working on the inpatient side, especially, it's easy to just start a medication and then not really ever think about it again, right? You're like, okay, patient's being treated with that, whatever. In order to help prevent that, in a lot of cases, you'll see the automatic stop dates will be put on some of those antibiotics. So we say 2 weeks, right? So at the end of 2 weeks, you should really have had a decision on whether or not that antibiotic needs to be continued, should be switched, or can just be DC'd. A lot of time it can just be DC'd at that point. But you'd have cases where patients were getting treated for weeks for an infection they didn't have anymore, right? Because no one's going back through and actually looking at the MAR and making sure that they were on all the appropriate stuff. Yes?
So what does that do to the bacteria? If it's too short, the bacteria will come back, but if it's too long, then what?
So again, when I'm applying an antibiotic, it's very rare that you actually eliminate 110% of all the bacteria that are there, right? So anytime I'm applying this selective pressure against the bacteria, there's going to be certain strains that may not actually be killed by that, right? So they may not be super fast growing, so they won't really be the predominant organism, but they're still there, right? So if I go and kill off the 98% that was susceptible to that antibiotic, and I keep treating it over and over a period of time, that resistant strain is still there, they're like, well, great, I'm the only ones left, I can keep growing now. So now all of a sudden they start to reproduce, and now you have a more resistant bug that's there. You should give them more time to really kind of supplant the other one that was previously predominant. Any other questions? Sorry, I keep drinking, I have like a really sore throat, so I'm trying to make it through this. Okay, so what are some of the factors that we use when deciding what type of antibiotics we're going to be using? One, you want to know your spectrum of activity, and this is going to be a big thing we're going to hammer on for this group of lectures, is it knowing your spectrum of antibiotic activity. So if I say you suspect your patient has MRSA, I expect you guys to know which antibiotics are going to cover that. Or if I say your patient has Pseudomonas, expecting you guys to know what covers that, or an anaerobic infection, or general gram-negatives or gram-positives, and we'll see into the different antibiotic classes, like how I have that kind of differentiated there. You're also going to look at the pharmacokinetics. You're going to look at things like, can this patient absorb the drug appropriately? How's it going to be distributed? How will it be eliminated? It's really important because a lot of these drugs are renally excreted. So what does that mean if you have a really sick ICU patient? When they get septic and they get hypotensive, what happens to your renal function? It goes down. So if I'm not clearing that drug as well, now I start accumulating it, what am I more likely to have? Toxicity. We don't want that. So elimination is going to be really important when we're looking at the pharmacokinetics of the drugs. As far as the dynamics of it, we'll talk more about these in depth, but we'll look at whether or not the antibiotic is going to be bactericidal versus bacteriostatic. It's a very important thing to look at. We'll look at whether or not the antibiotic is a time-dependent killer or a concentration-dependent killer. Okay, and then you also look at your toxicities as well. So, do you look at having very significant GI toxicities, hematologic toxicities, CNS ones? We'll look at all of those, and you may avoid a certain antibiotic because your patient may be really predisposed to one of these toxicities, and you may lead you to choose a different one instead. Right? But we'll talk all about those when we get to the specific antibiotic classes. Okay, so the first thing we'll mention here is whether or not an antibiotic is going to be bactericidal versus bacteriostatic. So when I say bacteriostatic, what does that mean to you guys?
Just keep it from growing more.
Exactly, but does it actually directly kill the bacteria? No, right? So if I'm not killing off the bacteria, then what am I relying on?
The immune system.
Exactly. So anytime I'm giving an antibiotic, I'm kind of counting on the immune system to kind of help me out, right? So kind of help to knock the bacteria down, help to prevent them from reproducing. But then I have my immune system come in with all my white cells and all the good stuff, and they come in and they'll take out the rest of the trash, so to speak. So that's pretty good. That works for most people. And what you'll see is that typically most things that are working on protein synthesis, things that are working on your ribosomes, for the most part, they're going to be bacteriostatic, right? Because I can work on these proteins and I can prevent them from being reproduced, and that's not necessarily going to kill off the bacteria because they can still survive with what proteins they have. Eventually they may die off, but for the most part, they're bacteriostatic. They can't really keep reproducing. So things like your macrolides, things like your tetracyclines, things like your trimethoprim, your sulfonamides, clindamycin falls in this category. Those are all bacteriostatic, so that's fine and good. And then you have your bactericidal group. And so these are mainly going to be the ones that are working on either DNA replication, so you see like your fluoroquinolones fall in there, or they're going to be working on the cell wall. Because if I inhibit that cell wall from continuing to grow, what happens to the cell? lysis open, all the contents go flying out, it's donezo, right? So bactericidal is going to be good for patients who maybe don't have the best immune function, right? So say you have a patient who's got cancer who just received chemotherapy and their neutrophils are non-existent. Well, they don't really have a great immune system to help fight off these bacteria. So I can, give them a bacteriostatic agent all day long, but eventually the bacteria are going to keep growing once I remove that antibiotic pressure. It's not necessarily good. Whereas on the other hand, if I give a bactericidal drug, I can just go ahead and wipe them out and I'm done with it, right? So looking at your patient, looking at the immunocompromisation state can be really important because you want to make sure that you're giving something that's bactericidal when they need it, and otherwise if they have a good immune system, then bacteriostatic agents may be appropriate, right? That makes sense? Okay. The next thing we got to look at, and this is also really critical for the way that we dose antibiotics, and so this is a really important concept, concentration dependent versus time dependent killers. Concentration dependent killer means that the higher the concentration that I drive up for that antibiotic, the more bacteria it's going to kill off, right? And so it's going to come back to this concept of MIC. You guys know what MIC means?
Minimum inhibitory concentration.
That's right. Minimum inhibitory concentration is your MIC. What does that level mean to you?
The least amount of drug you can give to cure the patient.
At least not a drug you get to achieve like certain.
The minimum inhibition of the bacteria, right? So basically it's a level of drug, it's a drug level that you must achieve in order to prevent that bacteria from reproducing anymore. The minimum inhibitory concentration. So if I'm below that, what happens? Bacteria keep reproducing. If I'm above that, no more reproduction, right? So in general, you want to be above your MIC. Okay. For concentration-dependent killers, the higher you get above that MIC, the greater proportion of those bacteria you're actually going to be able to kill off. Okay. Higher level, more killing. They also have what we call a post-antibiotic effect, which means that even though I give this drug and say the level of the drug becomes non-existent in the body, you would expect that the bacteria keep growing because the drug level is below that MIC, but because of whatever reasons, several, they're postulated, there's this post-antibiotic effect where even though the drug level is 0, they still continue to have inhibited growth, still killing off some of those bacteria. Okay. So post-antibiotic effect is really important for these concentration-dependent killers. So if you had to guess how often I might dose a concentration-dependent killer, what would you say? Very frequent or not very frequent? Not very frequent, right? Because I can just give a big dose, let the levels drop, and I know I'm killing those bacteria for whatever period of time. So typically, concentration-dependent killers, you're going to be seeing given less frequently. So things are given once a day, probably going to be a concentration-dependent killer, right? On the other hand, you have time-dependent killers. And the extent of killing that happens with the time-dependent killer is only going to happen as long as you're above that MIC. As soon as you drop below it, there's no post-antibiotic effect, and that bacteria is going to start to reproduce. So for time-dependent killers, I want to stay above the MIC as long as possible. And so how am I going to do that?
The steady state.
Frequent dosing.
Keep going.
Continuous dosing.
Yeah, the dose so that you stay at the same
You
concentration.
give it
So
more frequently.
Exactly.
less and then more frequent.
Yep, so you give the drug more frequently, or in some cases you give it by continuous infusion. And the idea is that when you achieve steady state, which takes how long?
4 to 5 half-lives.
Yeah, 4 to 5 half-lives. So once you achieve that steady state, which should be above the MIC, you're going to see this nice vacillation that can occur depending on your dosing, or a nice straight line if you're giving a continuous infusion that keeps you above that MIC for as long as possible, right? So you see things being given more frequently. So things that are dosed Q6 hours or Q8 hours, typically they're going to be dosed that more frequently in order to keep them above that MIC for longer, right? Ideally, you do a continuous infusion, but what are some problems with doing a continuous infusion of a drug?
Patient's going to be there the whole time.
They're gonna need something.
Well, the patient's stuck on the drug, so what if I have to give another drug? That's my only line. That's not really going to work, right? What's going to happen if a patient needs to go off the unit or something? There's a lot of logistical problems that come in with giving continuous infusions. Not to say that it doesn't happen. Certainly in ICU patients, you see continuous infusions of vasopressors and things like that. But usually your antibiotics, you want to be given as intermittent infusions several times a day instead. Oh, sorry. Okay, so one question did come up. There's an acronym I did not elaborate on. It was AUC. Does anyone know what that means? Just like in calculus, right? It's area under the curve. Essentially, that's the amount of time, or basically the time that the drug is at a certain concentration of where you want it to be. So essentially, when you're looking at the previous graph, it would look at AUC divided by MIC. And so a bigger number for your concentration-dependent killers would obviously be a better thing, right? Because you want to have a higher number above there, you're going to have a higher AUC, and there you go. Whereas on the time-dependent killers, obviously you want all of your time to be above the MIC. See how that compares to the AUC. It's not really such a super important concept for our purposes, but someone's asking, like, do you use that MIC versus AUC to figure out the dosing and whatnot? No, because the dosing has already been figured out by the drug companies previously. Like, that's how they do all their clinical trials, and that's where we get the doses from. But certainly, when you're looking at things like impaired clearance, that's obviously going to be altering your AUC as well. So if I had a drug that was renally eliminated and I were to have someone's renal function, say, drop by half, what does that do to my AUC? It's going to increase it pretty significantly, right? So in which case I may be more predisposed to toxicity. So that'd be one of those cases where I'd actually end up, say, maybe giving a lower dose, or I'd say we give the drug less frequently in order to help account for that and to make sure the patient has a level that's still where it should be, but they are not going to be accumulating so much drug that they become toxic, right? Any other questions from the first hour? All right, moving on. So the first group of antibiotics that we'll talk about are going to be agents that are affecting the cell wall. And so you'll see that there are many different agents that fall into this category of cell wall synthesis inhibitors. We're going to be talking about our beta-lactam antibiotics. See, those kind of fall into a lot of different categories as well. So you'll have your penicillins. We'll look at our cephalosporins. You see they have lots of different generations there. We'll have our carbapenems and then also monobactams. And then we'll look at other antibiotics that affect cell wall synthesis, including things like bacitracin, vancomycin, and daptomycin. There's two other ones that are not listed on the slide, but this is the first group we'll talk about today. It's probably most likely what we'll get through. So the first group is going to be our beta-lactam antibiotics. Obviously, if you can tell here with this kind of square structure, that's the beta-lactam group. Now, if you were to have an allergic reaction to a beta-lactam, which part of the molecule do you think you're actually having a reaction to? Oh, someone said the R. Interesting. So actually, no one really has the allergy, or it's not common that they would have the allergy to the actual beta-lactam group, that square component with the nitrogen and the double bonded oxygen there. Usually it's the R group is what they're responding to, right? That's what they're having an allergic reaction to. So, which is why, when we'll talk about cross-sensitivity and allergies and whatnot, but it's very rare that if you had someone who had an allergy to penicillin, and you won't be able to get that on the video, but I air quoted, if you had a legitimate allergy to penicillins, that you will most likely not have a reaction to cephalosporins. Right, we'll talk about why that is in a little bit later, but just realize that the R chain is what's really going to be changing from molecule to molecule, but that beta-lactam group is going to stay the same because that's where the majority of the mechanism of action is going to be coming from. So essentially what the beta-lactam group is doing is it mimics these two D-alanines, and D-alanines are really important for producing the cell wall. It's going to help a lot with the cell wall synthesis, a lot of the cross-linking and all that peptidoglycan that's going to be on that outer cell wall. But basically the beta-lactam ring is going to be the kind of the business end of the molecule. There is a molecule called penicillin binding protein that works to basically help with the function and the production of the cell wall. What the beta-lactam is going to be doing is going to have this penicillin binding protein, that PBP, bind to the penicillin, and it's going to form this covalent linkage, and basically it's going to inactivate the enzyme. Now this is how all of the beta-lactam antibiotics are going to be affecting cell wall synthesis. You'll see other ones that are going to be more directly affecting the cell wall, not necessarily this enzyme. But here you see beta-lactam antibiotics are inhibiting this penicillin binding protein. So if you were a bacteria and you were to develop some resistance to this mechanism, what might you do?
Change the PDP.
Okay, so I could change the penicillin binding protein. That's absolutely one method of resistance. If I change the enzyme enough to where the penicillin can't bind it, then it's not going to be effective. Perfect. What else could I do? What if I had another molecule that came and just cleaved that beta-lactam group? Something like a beta-lactamase. So some bacteria produce beta-lactamase that will actually cleave open that beta-lactam group and inactivate it. So that's another method of resistance to the beta-lactam antibiotics. So again, you can see here, as most or all of the penicillin binding protein molecules are inactivated, basically the cell wall cannot synthesize these new peptidoglycan chains, and because of that, they can't make these new crosslinks, and thus you're eventually going to have cell rupture, and that lysine, with all the content spilling out, is what's going to end up killing the cells. So we talked about bactericidal versus static. Which one do you think this is? This is a cidal. This is a bactericidal group of antibiotics. So would it be better or worse for someone who had a compromised immune system? Be better for them, right? Because this doesn't necessarily rely as much on the host immune response in order to help get rid of the bacteria. So penicillins fall into a number of different categories, and so I try to put this little kind of stoplight system here to help you guys kind of compartmentalize the coverage that different antibiotic groups are going to have. Right. So the first ones we'll talk about are the natural penicillins. Again, penicillin came from mold way back in the olden days, and it was this huge advancement in modern science. And so we see the main category, or the main constituent here is going to be this penicillin G, right? So penicillin G, in general, is going to have good activity against gram-positive cocci, but unfortunately it does not have any staph coverage, right? So we talked about methicillin-sensitive Staph aureus, and you'll see that penicillin itself is kind of a really prototypical antibiotic. It really doesn't have a lot of that advanced features that later penicillins have, so it doesn't have any real staph coverage. Okay, it has kind of okay anaerobic coverage, but it's not going to cover Bacteroides. So in general, penicillin's a really narrow spectrum kind of antibiotic. It really doesn't treat a whole lot of different stuff, but because it's kind of a tried and true one, it does treat a number of things as a drug of choice for different things like syphilis, gas gangrene, and even some strains of meningococcus. But notice it has really no activity against gram-negatives. So say I were to have an abdominal infection, would penicillin be a good choice? No, because that's a lot of gram-negatives, some anaerobes. It's not really going to cover it very well. If I have a UTI, what would you say?
Gram-negative, no good.
Again, yeah, gram-negatives are the predominant organisms in UTIs. This probably isn't going to be that good of an organism, or a good thing to treat with. However, say if I had, say, strep pharyngitis, that's a streptococcus that is causing that, penicillin might be okay for that, depending on your resistance patterns and things like that. So again, pretty narrow spectrum antibiotic, but it does have some specific uses there. So notice that penicillin itself is not dosed in milligrams so much as it is in units, right? So this one you'd see 18 to 24 million units divided every 4 hours. So what does that tell you about the way that it kills the bacteria? Is it time dependent or concentration dependent? It's a time dependent killer, right? So because I'm giving it very frequently throughout the day, I have to give it in order to keep it above the MIC. So every time the concentration starts to drop, I give another dose to pick it back up before it drops below that MIC, right? And usually you want to be several times above the MIC to make sure that you are actually killing off that bacteria to an appropriate extent. So,
specific definition for a unit, or is it based on each different drug?
It's based on activity. So like a unit of insulin is obviously going to be different than a unit of penicillin, right? So it's just kind of based on the activity. This is what they say is a unit of penicillin. There is a milligram equivalent, but usually people don't dose it by that. Usually based by units. This is really the only antibiotic you'll see dosed by units for the most part. So as far as monitoring goes, obviously anytime you're giving an antibiotic, you want to monitor for signs of efficacy. Obviously, you want to make sure that the patient's getting better, their infection is clearing, but also look for signs of anaphylaxis as well, because this can be one that some people have allergic reactions to. And when I say allergic reactions, what kind of things am I talking about?
Anything from rash to hives.
Rash, hives. How about nausea, vomiting? Not an allergy.
Side effect.
How about diarrhea?
Side effect.
Not an allergy, right? Okay. So when people say I have a penicillin allergy, what's your next question?
What's your reaction?
What kind of allergy? What happened when you took it? They say, oh, my throat closed up. Okay, that's an allergy. They say I need an EpiPen. That's an allergy. Okay, so it's important to delineate between the adverse reactions and adverse reactions and true allergies, and to ask the follow-up questions, because otherwise, if someone says I'm allergic to penicillins, that knocks out a whole lot of drugs that you don't want to necessarily do unless you have to. There's a couple different dosage forms that you see. So if you ever see the different letters after the penicillin, this is kind of what it's referring to. So penicillin G, or benzyl penicillin, is not particularly a sturdy molecule. So if I were to give it orally, the stomach acids would end up inactivating it, and I can't really absorb a whole lot of it. That's going to be useful for me. So instead, they made a more stable form, and so this is where you see this penicillin V potassium. This is phenoxymethylpenicillin, or penicillin VK is sometimes how you'll see it noted. These are going to be your oral dosage forms for penicillin. There's also a nice long-acting form. So remember we talked about solutions versus suspensions, and do we say, do you ever want to give suspensions IV? You don't, right? Because you worry about what? About embolus, and you really don't want to cause that for your patient. So there is a suspension form of penicillin. So you have this benzathine penicillin G, otherwise known as bicillin. This one is available for IM administration. You notice here it's hard to tell, but it's a very kind of milky texture to it. I guess not texture, but a very milky kind of look to it. It's basically in a solution, or it's in a suspension, I should say, that allows for long-acting duration of action for this. So this is actually really nice in some cases. So say you had a patient who, and I've had cases like this where I was treating a young child for strep pharyngitis, and normally you can give oral things like amoxicillin or something like that. This patient they could not swallow, right? Well, the nice thing about this bicillin LA, what's the LA stand for? Long acting. I could just give them an IM shot of this stuff, and then because of the release characteristics of it, it would only have to give a one-time dose, right? So kid has to get a shot, which is unfortunate, but they were able to get just one dose and be done with it. Okay, so this is a nice dosage form that even though it's a suspension, you can give it intramuscularly, but you would never give it IV. Okay. We'll talk about general adverse effects and other things as a group in just a few slides. But the next group of penicillins is going to be the aminopenicillins. And so remembering which ones are the aminopenicillins are kind of easy because they start with A, right? So you have your ampicillin, which can either be given IV or PO, typically given IV, and then your amoxicillin, which can be PO only. I put the dosage forms on here just for your guys' sake. I'm not going to ask you necessarily, does ampicillin come IV or PO? Like, I don't really care for you guys to know that. You can look that up, right? I'm only putting it here more for your reference than anything else. Now, I may ask which dosage form may be appropriate for a patient based on their certain characteristics, like that child I just talked about. So that's kind of stuff that may come up. So, which dosage form is going to be appropriate based on your patient characteristics. So you have your amoxicillin, you have your ampicillin here. The nice thing about this is that they have a little bit better activity against gram-positives. Still no staph coverage, though. Important to note, you're not going to get any staph coverage with your aminopenicillins. They have a little bit of anaerobic activity, very similar to what you'd see with your penicillins. And here they get a little bit of some gram-negative aerobes, but for the most part, you're not going to see a ton of coverage for that. The one thing that they are good for is that they're going to be the drug of choice for Enterococcus. That's going to be especially good to note because we'll talk about our cephalosporins in a little bit that as a class do not actually cover an Enterococcus. So that's good to know. They're also good for Listeria. So actually ampicillin is going to be your drug of choice for Listeria, and that's important to know for certain things like meningitis. So especially if you have like really young kids who are neonates and you need to treat them for meningitis. If you're worried about Listeria, this would actually be one of the antibiotics you'd want to include in order to cover for that, because not a lot of other drugs really do that so well. This is also good for endocarditis prophylaxis, like we'll talk about when we get to cardiology. It can be used for some upper respiratory tract infections, things like sinusitis, otitis, and then it's also going to be good for community-acquired pneumonia. But note that especially for some of these lower respiratory tract infections, you're going to be using higher doses in order to overcome any chance for resistance that might pop up. Note here, these are still going to be time-dependent killers. We're still giving these drugs very frequently. And what's kind of the drawback of using a drug that you have to give every 6 hours? Compliance is a huge thing, right? So if I have to give a kid a really nasty-tasting drug every 6 hours, it's probably going to be pretty difficult, right? So that's one of the things you have to always consider is the compliance aspect of it. That's why things like fluoroquinolones, we said are a concentration-dependent killer. You only have to give once a day for some of them. That's why it's so easy just to say, oh, you come in with sinusitis, here's here's some Levaquin, just take it once a day and you're good to go, right? But that's going to be inappropriate, as we'll see when we look at things like coverage and making sure we're not having resistance pop up. Some of the interactions you'll see, and this is very similar to the penicillins as well, so you can kind of lump those two together here for this. With anticoagulants, especially things that are vitamin K antagonists, so things like warfarin. You guys ever heard of warfarin? It's a blood thinner, right? So it's a pretty common one. It works by antagonizing the effects of vitamin K. The penicillin and immunopenicillins can actually increase your prothrombin time and increase your INR because it has this interaction where it's able to make the bleeding risk a little bit higher. The other thing you always have to consider as well, and I was kind of reading up on this in some of the more recent literature, is that there's kind of an old school mentality that when you're given these antibiotics, there's a chance you might have decreased effectiveness of oral contraceptives. Have anyone ever heard of this? Or if you're taking antibiotics, you use a backup form of contraception, right? Actually looking at the data, and it's not super great to actually really recommend that in a lot of cases, but generally as a class for antibiotics, the reason why we worry about that is that estrogens, when they are taken orally, they end up undergoing enterohepatic recycling. You guys ever heard that term before? Essentially what happens when you have estrogens that are taken orally, they get into the systemic circulation, they're eliminated within the bile. So what happens is they get basically conjugated with these bile salts, they get eliminated through the bile tract, and they're out back in the GI tract, right? Gut flora can then cleave that binding, allow the estrogens to be free again, and then they can be reabsorbed into the systemic circulation. So the idea is if I give an antibiotic that clears out all this gut flora, or alters it to some degree, you're going to have less of that recycling happening, and thus your blood levels of estrogens can actually drop. So that's kind of the reason why they say if you're on an antibiotic course, you should be on a backup form of birth control. So that way, especially because people are sometimes not great about taking their meds all the time, right? If I ever have to take a medicine, I'm terrible about it, right? I don't take it like I'm supposed to. If I know better, people do that all the time too, right? So no one takes their drugs perfectly. And so the thought that any decrease in blood levels could potentially increase that risk of having an accidental pregnancy is something to be avoided. So I would probably still recommend everyone use a backup form of birth control to my patients. But the literature doesn't necessarily always support that. So this is kind of a class thing with all antibiotics, I would mention, at least from the oral perspective, right? Does that make sense?
Yes.
Yes.
But so, if gut flora isn't, if you have the gram opposite of what's in the gut, it's probably not going to affect it, the birth control.
No. So your gut flora can be affected by almost any of these antibiotics.
Oh, okay.
Yeah, so even if you're given IV antibiotics, you can still have disruption of the gut flora because there's all a whole microbiome of different things down there. So disrupting that can really lead to some. This is where you see a lot of C. diff colitis comes from, is because you disrupt that natural flora, and then C. difficile can kind of take over. They get kind of a foothold and can develop there. So really, anytime you're taking antibiotics, there's risk. Certain antibiotics will be more at risk for that, especially ones that have really good anaerobic coverage. We'll talk about one of those in a second. Definitely a risk. Other side effects that you'll see with the penicillins and the immunopenicillins include rarely you'll see some hepatic dysfunction, things like hepatitis, jaundice. May see some increases in your lab values there. Obviously, anytime you're taking antibiotics, you run the risk of having a C. difficile infection. It's not always going to happen. It's more prevalent in patients who are, one, immunocompromised, and then also if you're on the kind of repeated course of antibiotics. And we'll also talk about some that are more prone to cause it than others, but there's always that risk there. And we mentioned rash can occur with penicillins. And so this is something that is a normal side effect, does not always denote that they're having an allergy. Could just have a rash with it. That can lead to some pretty significant effects, though, these kind of the autoimmune reactions. Have you guys heard of Stevens-Johnson syndrome? Talked about that a little bit before, I believe, where basically it's this whole condition where you have lots of skin sloughing off. It can be really, really bad. Toxic epidermal necrolysis kind of follows into that same category. So if you see TEN, that's what I'm referring to there. They look very, very similar to one another.
What was TEN? Sorry?
TEN is that toxic epidermal necrolysis. Yeah. So again, these are just really these really nasty skin reactions where it's having lots of sloughing. It can be fatal if it's not caught early. It needs to be really aggressively treated. You can also have some issues with interstitial nephritis, hematuria, crystalluria, and then you may have some blood dyscrasias, things like anemia, thrombocytopenia. But in general, these are pretty well tolerated for the most part. The only real contraindications you should note is that they have a previous allergy to penicillin, especially if it's a true type 1 allergy. You probably want to avoid these. And then maybe as a relative contraindication, if they have a history of cholestatic jaundice or hepatic dysfunction. But again, for the most part, it's very well tolerated. You don't really run into too many patients that fall into these, that would be absolutely contraindicated from it, other than the allergy thing. Again, one of the big things to note with the majority of penicillins, actually I think all the penicillins, is that renal function is something you really need to consider, right? So again, anytime you're treating a patient who you suspect may have some degree of kidney reduction in function, you really need to check your dosing to make sure you're dosing it appropriately for them, because as they are renally eliminated, if you have a decrease in function, you're going to be accumulating drug and you're more likely to run into toxicity. Okay. As far as monitoring goes, again, look at renal hepatic function and platelets as well, something to look at potentially. If you're just on a short course, unless you have any other reason, if it's an otherwise healthy patient, I probably don't need to do a whole lot of lab monitoring from that standpoint. Okay, again, like we said, you can have resistance in the way of changing the penicillin binding protein, but you can also have cleavage of the drug due to the beta-lactamases that are being produced. They will actually end up cleaving that, opening it up, and then the drug's going to be not effective anymore. Okay, so what are some ways that we can overcome beta-lactamase? Beta-lactamase inhibitors, right? Try to keep it pretty straightforward for as far as naming things. Now, these inhibitors, they basically have no antibacterial function themselves, but what they do have the ability to do is basically to tie up beta-lactamase and prevent it from getting to the actual effective molecule, right? So there are three main ones you're going to see. One being sulbactam, you have tazobactam, and then you have clavulanate/clavulanic acid. Basically, two names are the same thing, right? You never see these drugs given by themselves. They will always be in combination with another drug. And the nice thing that these are going to do is to help overcome that beta-lactamase, and it also will help to increase the number of the different types of bacteria that these drugs are able to treat. I'll show you some examples of that in a second. So adding an aminopenicillin plus a beta-lactamase inhibitor really does wonders to increase its coverage. So the two big ones you're going to see in this category include augmentin, which is going to be your amoxicillin plus clavulanic acid. And then you're also going to have unicin, which is ampicillin and sulbactam. Okay. The nice thing is this increases the anaerobic coverage, which means now it's going to start to cover Bacteroides. It will cover MSSA, that methicillin sensitive Staph aureus. So now we'll cover some MSSA. And in a lot of cases, you'll see this being used for skin and soft tissue infections, especially if you're worried about anaerobic bugs being there as well. So in the case of things like dog bites, cat bites, people bites, they happen. This would be a case where you'd want to cover for these gram-positives, things like staph, and also cover for your anaerobic coverage as well, because again, like we said, the mouth full of anaerobes. This is also going to be helpful for some intra-abdominal coverage, and then also diabetic foot would be another case where you get lots of anaerobes and gram-negatives and things might be there. These would be some of the better choices for that, right? Usually if you hear of something like an aspiration pneumonia, aspiration pneumonia is when you end up having gut contents come up and getting aspirated into the respiratory tract. Again, you're worried about gut bugs in the lungs at that point, so you're worried about gram-negatives and anaerobes. This would be a case where unicin would be a good choice for that. Okay. Okay. The next group we'll have is going to be our penicillinase-resistant penicillins, otherwise known as anti-staphylococcal penicillins. So this is where methicillin would have fallen into if we still really used it anymore. Again, there's other penicillins that fall in this category, but I only list the ones that are really used clinically that I see very often. So nafcillin, oxacillin, and dicloxacillin. The big name to fame for these guys is going to be that they cover MSSA. Now, if you had someone who's worried about MRSA, these would not be a good choice, right? Only MSSA are these really going to be covering. They also have decreased activity against a lot of other bugs. So because of the fact that MRSA is becoming an emergent organism, you're going to see more and more of it. These guys are not super great as empiric coverage for things because their spectrum is so narrow. But what I will see a lot of times is that patients will get admitted to the hospital on broad spectrum coverage, say something like a vancomycin, which covers all kinds of gram-positives. And then once we get the culture results back and it's MSSA, we can de-escalate onto one of these, right? So this is a good option for that. But again, not broad coverage, not really good for good empiric therapy. Again, these are going to be very similar. Most of these are only available IV for the most part, so you're really going to be seeing these more on the inpatient side. Again, side effects are going to be very similar to the other penicillins, similar monitoring. Again, looking at renal function is going to be really important for these guys to make sure you're dosing it appropriately. These are some that you might actually see being used as a 24-hour infusion. So there's been a couple times, like in the surgical ICU, where I've seen some cases where they're using 24-hour infusions of this stuff. But again, it's kind of inconvenient from a logistic standpoint in treating these patients. The next group is going to be anti-pseudomonal penicillins. So as you might imagine, what kind of bugs are these going to cover? Pseudomonas, hopefully. Hopefully you don't have really nasty pseudomonas that won't be treated by these. But the one that falls in this category is going to be piperacillin. It used to be made by itself, but I can't actually find that it's really available like that. You'll never see it used that way anyway. So piperacillin tazobactam, and again, tazobactam is what? The beta-lactamase inhibitor, right? It's the only reason why you really add another drug into a beta-lactam is to prevent that degradation. So piperacillin is the active component. Tazobactam is the beta-lactamase inhibitor. Helps to make piperacillin work better, right? So this guy is really, really good for empiric coverage, which also makes it really ripe for inappropriate use. So it retains really broad spectrum coverage against MSSA. So it covers that. It doesn't cover any MRSA. It has really good gram-negative coverage, so it's able to cover things like Pseudomonas and other gram-negatives and Enterobacteriaceae. And then the other nice thing is that it has really good anaerobic coverage. So this is like green across the board. Like you're like, hey, this is an easy drug. Let me just throw this at everything. Not good, right? This is one of those ones that are oftentimes targeted or restricted in a lot of hospitals in order to make sure we're not overusing them, because these are so easy just to throw at everybody and say, okay, well, especially in the ED, you're just like, here, I have a dose, and I'll send you upstairs, and ICU guys will figure it out later, right? So this is really going to be the drug of choice for a lot of polymicrobial infections. So if you're worried about having multiple bacteria that might be causative, this would be a good drug for that, especially nosocomial infections with gram-negatives or anaerobes. So for like pneumonias in the hospital that develop, say after a ventilator has been in place for a long time, this would be a good drug for that. And then the nice thing is, because this covers anaerobic bacteria, this is good for intra-abdominal infections as well. So especially when I have patients who are coming into the ED who have got a ruptured appendicitis, and the docs are really worried about having all those gut contents kind of leaking into the intra-abdominal space, they'll cover it with Zosyn, right? Because it's going to be able to cover those gram-negatives in the gut and also cover for those anaerobic bugs. Make sense? So if I were to treat someone who I was not worried about anaerobic coverage, probably going to try to avoid this one. And I'll show you the alternative that we can use in a lot of cases in just a little bit once we get to the cephalosporins. But again, this one's really easy to overuse and to use inappropriately, so we try to avoid that as much as possible. But it's a really good drug otherwise. Again, this is one where it's going to be dosed every 6 hours, typically. One of the cool things that they're actually trying to do, and they've actually seen improvements in mortality in certain ICUs, is using this idea of extended infusions of the drug. So we talked about this drug. Is it a concentration or time-dependent killer? It's a time-dependent killer, right? Because we're giving it every 6 hours, must be a time-dependent killer, right? So one of the things they were saying, well, if I were to give this by a continuous infusion and keep it above that MIC for longer, right? Because I can just keep it at that steady state, hopefully. They were postulating that I can give it less frequently, but give it for a long period of time, say over 4 hours, and then you would have better outcomes. And what they're actually able to find is that, yeah, they actually had improvements in mortality by giving this drug less frequently, but over 4 hours, and keep it above the MIC as much as possible, you saw a lot better results. So that's one thing you may see a little bit change in dosing. If you ever see a drug given over 4 hours, 3 times a day, that's probably one of the things they'll do. They do this with some carbapenems as well, which we'll talk about a little bit later. Again, looking at dosing for renal function, it's a really important thing to look at. Adverse reactions are going to be very similar to the other penicillins, and the monitoring is also going to be pretty much the same, right? So again, nothing really big with these penicillins as far as oddball reactions you really need to worry about. It's going to be the same across the board for the majority of them.
With the bleeding.
Again, that has to do with the platelet dysfunction you can see. And so that'd be one of the things you want to be looking for, the platelets on that CBC to make sure you don't have any drop in that, right? But of course, yeah, if you had warfarin on board as well, you could see potentially prolongation of your PT due to that interaction there. Usually, though, when the type of patients you're giving this to, they might be having blood dyscrasias for other reasons as well, like they're like super septic or whatever happened to be going on. So this might be something you're just monitoring in conjunction with anyway. And dropping platelets might not necessarily be due just to this. So it's one of the things where it's like, could be any number of reasons. Okay, any questions on that? Moving on, we then have our cephalosporins. Notice how they have a very similar beta-lactam ring, but everything else is kind of different between them. So the R chains are going to be different. They have this dihydrothiazine ring here. This is basically the general structure for all the cephalosporins, all the generations that we'll end up talking about. So some of the benefits of cephalosporins, why we like to use them, is that one, they have good cerebrospinal fluid penetration. So what would that be good for?
Meningitis.
Meningitis, absolutely. So this is why you see cephalosporins are going to be one of your first-line drugs, or acephalosporins are going to be your first-line drug for meningitis. Because again, if you're looking at the blood-brain barrier, how easy is it to get across?
Not easy.
It shouldn't be, right? Because the idea of the blood-brain barrier is it keeps everything out, right? Because you don't want a bunch of random stuff going up to your brain. That's not good. It's a really protected site. What happens when you have meningitis, though? What happens to that blood-brain barrier? It's inflamed, gets more leaky, more stuff can get through. So you'll find that there are some antibiotics that can cross the meninges, no problem. They can get into cross the blood-brain barrier, no problem, 24/7. There are some antibiotics that will only cross when they're inflamed. So you see those increases in those gaps in those pores, and that's when some antibiotics, especially bigger ones, things like vancomycin, are able to cross a little bit easier. And then there's some drugs that will never cross, right? They're just either too bulky, or they're too polar, or whatever it happens to be. They're not able to cross that blood-brain barrier. So these are good, though, because they do cross, and they're good for meningitis. Going back to that penicillin cross sensitivity. So if someone says, I have a true blue, I have, my throat closed up when I received penicillin, I can't receive this stuff, would you give them a cephalosporin? See a lot of brave people here.
Yes.
Yeah.
You said it's less than 1%.
I said it's less than 1%, so what your farm teacher says must be right, right? I hope so. You should always double check me. Never believe me, just what I say on the slide. So what happened is that back in the day, we used to not have all these nice synthetic means to produce things like penicillins and cephalosporins. How do we used to produce a lot of drugs?
Rabbits and stuff?
Usually like bacteria. You'll see some drugs we do actually produce proteins from with rabbits and mice and sheep and all kinds of stuff. But a lot of drugs were produced from bacteria. And so, you'd have very similar bacterial strains that were producing things like your penicillins and also producing a lot of your first-generation cephalosporins. And so what would happen is there's actually there's contamination where you'd have, it's kind of like the Reese's where you have cephalosporins in your penicillins and penicillins in your cephalosporins. And so that's where a lot of the cross-reactivity would come from, because even though you're getting a cephalosporin, you're secretly still getting some penicillin in there too, right? What they found was that you actually look at the literature is that people who have a true type 1 allergy to a penicillin have less than a 1% chance of having a cross-reactivity to a cephalosporin, right? Your biggest risk is probably going to be the first generations because they share a little bit more structural similarity with some of your penicillins, some of your immunopenicillins. So that's probably your highest risk, but as you get farther along in the generations, your risk decreases quite a bit. And it all comes back to the side chains, right? The R chain is really what's going to be causing that cross-reactivity there. So the more different that side chain is, the more likely you are to not have a reaction between the two. The beta-lactam ring really doesn't matter. It doesn't really factor into it too much, right? Make sense?
What does generation refer to?
I will talk about it in just a second, but there's different generations of cephalosporins, and I'll show you that in just a second.
Is there a way to test without actually giving them the dose whether or not they're allergic?
So not usually like in the clinic, you'll have or in the clinic or the ED type setting. You're never really going to do like a skin test to see if they have like a wheel and flare reaction, because that's not always going to be 100% sensitive to those people that are truly going to have a cross-reactivity. I worked with an immunologist at Nemours who he would actually he'd be consulted in cases where, like, say, for instance, a kid was going to surgery, he got a bunch of different medications, and then he had a reaction to one of them. They weren't sure which one. They would actually go into his office, and they would actually give him small increasing doses of the drug, increasing concentrations to see which one he had a reaction to. So sometimes you can get a referral out, and they can determine whether or not you'd actually have a reaction. But a lot of times, I'll tell you what, if you're in the ED type setting, I have all the stuff I need to treat an anaphylactic reaction, right? So just on the off chance they're that 0.000 whatever percent it's going to be, I can still treat them if I need to. So oftentimes if I have really skittish providers who are like, I'm not really sure if I should give it or not, we'll give them a dose here. Give them the first dose here, see how they respond. If they're good in 30 minutes, send them on their way, right? So that's oftentimes what I'll do to try to kind of reassure them a little bit that cross-reactivity is really not going to be a big deal. Okay. You'll find a lot of old school providers that will absolutely not prescribe any cephalosporins to a patient with a penicillin allergy, and that's really a shame because that cuts out a ton of different drugs that could really be appropriate for those patients, right? So just call up your local pharmacist and have them yell at them and be like, that's not a big deal. Unless they're really old school pharmacists and they may not know. Anywho, so again, as far as side effects go for the class, very similar to what you might see with the penicillin. Again, looking for things like nausea and vomiting, look at things for diarrhea that are going to be just common side effects. And then obviously your CBC, you're looking for platelet changes at all. And then we'll talk about the spectrum of activity, and that's really going to be based on the generation of cephalosporin that we're talking about. I'll get to that in a second. As far as anti-pseudomonal activity, you guys remember the penicillin we said that had anti-pseudomonal activity? It was, started with a P.
Piperacillin.
Piperacillin. I like saying piperacillin. Piperacillin had anti-pseudomonal activity. There are two cephalosporins that have anti-pseudomonal activity. They're used commonly in clinical practice, and it's going to include ceftazidime and cefepime. That's a third and a fourth generation cephalosporin. I'll show you guys on the slide in a second. Really, you're only ever going to use cefepime for an anti-pseudomonal. Ceftaz is really not going to be too good for that. We'll talk about why in a second. And then again, for the most part, we'll talk about one notable exception, but these are all going to be eliminated renally. So again, you got to look at the renal function and change your dose appropriately, right? So in a lot of cases, when you're looking at time-dependent killers, which again, these are also going to be time-dependent killers, you're given multiple times a day. The way that you'll adjust the dose is to not necessarily change how much you're giving of the drug. You'll give it less frequently. So for someone who has a really significant renal dysfunction, I may, instead of giving the drug Q8, I'll give it Q12 instead. Or if they're really, really bad, I may give Q24, you know. So those are cases where you really need to adjust for your renal function, otherwise they're going to accumulate and cause toxicity. It's not going to be good. Okay, so looking at the progression of generations, you see that as one moves up in generation, you're going to be seeing more gram-negative coverage. Also, when you go up in generation, you're going to be seeing a decrease in gram-positive coverage. Until you get to the fourth generation, then it kind of goes back up again, right? Just keep that in mind that your coverage is going to change as you go. As a group, none of these are going to cover Enterococcus. So if you're ever worried about covering for Enterococcus, cephalosporins are not going to be your go-to drugs, right? That's why a lot of times you don't see these being used by themselves for things like intra-abdominal infections, because one, you'll see that they don't really have any anaerobic coverage, and none of them cover Enterococcus. So you miss out on a lot of good coverage for intra-abdominal infections. So you really won't see these used for that all that often, unless it's in combination with another drug. So the first generation cephalosporin, you've probably heard of some of these. One's going to be cefazolin or Ancef. Some people say cefazolin. I don't actually know which one's the right one, but I'll say cefazolin. And then you have cefalaxin, or your Keflax. Who's heard of Keflax? Pretty common one, right? So what you'll see is that these are, especially Ancef, which is the IV only formulation, oftentimes used for surgical prophylaxis, right? So if you look at the coverage of these, they have pretty good gram-positive coverage, because again, they're that first generation. They have okay gram-negative coverage. You know, they're still good for things like uncomplicated UTIs and whatnot, but no anaerobic coverage. So if I'm going in for surgery, if I'm about to slice someone open, what kind of bugs am I worrying about introducing into that site? Mostly gram-positive, mostly your staph and strep and things like that. So these will be okay. Notice that the first generation cephalosporins do cover MSSA. All right, so that's why it's really good for surgical prophylaxis. You can give them 24 hours of therapy, make sure they don't have an infection, and then you're good to go, right? So these are good for that indication. Cefalaxin you'll see used oftentimes for UTIs, usually uncomplicated UTIs, and then for some skin and soft tissue infections. Now this goes back to looking at your antibiograms to see whether or not the bugs you're looking for are really going to be covered by this. In some cases you may see that MSSA is 100% resistant to cefalaxin, and you wouldn't want to dose this. You would want to use a different drug, right? So look at your sensitivities in the area. And again, some gram-negative coverage, but pretty good gram-positive coverage. Still no MRSA. We still haven't encountered an antibiotic yet that really covers MRSA yet. Okay, so keep that in mind. Moving on, you have your second generation cephalosporins. Like we said, we're giving better gram-negative coverage, a little bit less on the gram-positive side. So here you see things like cefotetan, which is IV. You have cefoxitin, IV, and then you have some PO formulations like cefuroxime and cefprazil. This is probably the least commonly encountered one that I see, at least in my clinical practice. I don't see a lot of these being prescribed, but certainly can be. Here you're going to see more coverage for gram-negatives, things like H-flu Enterobacter, Neisseria, Proteus, things like that. And you'll oftentimes see these more used in sometimes for surgical prophylaxis, not too commonly, then sometimes for upper respiratory tract infections or UTIs. Next, you have a very important group, the third generation cephalosporins. The main one you're going to see being used very often is going to be ceftriaxone or Rocephin. This one can be given IV, can be given IM, and it's really good because it has great gram-negative coverage for a lot of non-resistant bugs. Still no pseudomonal coverage for ceftriaxone, but has decent gram-positive coverage. So this is really good for things like strep. One thing to note is that the ceftriaxone is completely eliminated hepatically, so you don't have to worry about renally dosing this drug, which is really good. So no renal dosing. This one is kind of the exception to looking at renal dosing for your cephalosporins, right? So that'd probably be something good to know. The other thing you have to worry about with ceftriaxone specifically is that when you give it into a neonate, neonates have a lot of bilirubin floating around, right? And usually a lot of those are being bound to serum proteins. Ceftriaxone can actually displace the bile salts from, or the bilirubin from the binding sites on the proteins, and actually can induce jaundice. So you never want to give ceftriaxone to a child in the first 30 days of life. We have a different drug for that. We'll typically give cefotaxime instead. So if you're worried about treating something like neonatal sepsis, cefotaxime is going to be a much better drug to go to in that first 28 days, for 28 to 30 days, and ceftriaxone is going to be for after that point. Ceftriaxone you see being used as first-line therapy for things like meningitis, because again it has good CSF penetration, has good coverage for most of the bugs that are going to be causing meningitis. So you see a lot of use there. The IM administration is really nice because you can get away with like 3 days of therapy just by giving it. It has a pretty long half-life for the most part. Easy way to remember how often to give ceftriaxone is that Ceftriax 1 time a day. So even though it's a time-dependent killer, it's a long enough half-life that I can get away with giving it 1 time a day. Sometimes you'll see it given Q12, especially for more severe infections, but for the most part, it's given once a day. And then you also don't want to give it with calcium in an IV line because that can actually cause precipitation and can either block off your line or cause an embolus in the patient.
What did you just say was IM? I'm looking for something IM.
The ceftriaxone can be given IM. So it's another frequent way. So if you don't have, if you have a patient like in the ED or something, and you don't have any IV access and you don't want to start an IV, then you can give it IM as an alternative. Not to say the patient's going to like you very much because it still hurts like the dickens, but you can do it. Yes?
Why does Rocephin cause jaundice?
It displaces bilirubin from serum proteins. So it's one of those drug protein binding interactions that we talked about like back in pharmacodynamics. So it can basically just takes all that bound up bilirubin and makes it free, and that can cause the jaundice to occur.
Does that cause the brain affect for the bilirubin as well?
Potentially, yeah, if it gets high enough, yeah.
Jaundice is ugly, but it's not really permanent.
Yeah. So just the first 28 days, you just avoid that one for them. Ceftazidime is not something you see used very often. It's nice that it has pseudomonal coverage, but the problem is that Pseudomonas has a really nasty ability to develop resistance to this bug or this drug very, very quickly. So what you end up seeing is that even though your culture may come back as being sensitive to ceftazidime, you may start treating with it, and then you apply that selective pressure. All of a sudden, you get a repeat culture. The bug's resistant to it. So clinically, you never see it being used for pseudomonal infections, especially as like empiric therapy. I've seen it used in some really kind of specific circumstances, like CF kids or cystic fibrosis patients. They grow all kinds of super weird bugs, so their mucus secretions are just so thick they just harbor like stuff you've never seen before. And so sometimes ceftazidime will be effective for one particular bug they happen to be growing. That's really the only instance I've seen it. So usually stay away from that one. Cefotaxime, like I said, is good for neonates. It's really good for neonatal fever and sepsis. And then as far as oral varieties, you have things like ceftonir, which is commonly prescribed, and also cefixime. So again, this group is going to have even better gram-negative coverage than you would see with your second-generation agents, but it loses a little bit more of the gram-positive coverage. You'll see better coverage for things like Serratia, Moraxella. So this is a class that gets used very frequently, but keep in mind that if you can get away with using simple first generation cephalosporin, do that, right? If your coverage is such that you're only worried about MSSA, that might be a better option to go with it, utilizing a bigger gun like a third generation cephalosporin. Again, just like we were talking about, once a day, Rocephin, ceftriaxone, that's kind of where that comes from, or at least that's the way I remember it. And again, you see these are still time-dependent killers, but just due to the half-life of ceftriaxone is why you can get away with giving it 1 time a day. But for things like meningitis, where you really want to get, so especially with those protected sites where you know it's more difficult to get drug levels higher, that's why you would give this drug more frequently, like every 12 hours, to really drive up concentrations in the CNS. Okay, next you have your 4th generation cephalosporins. The main one here is going to be cefepime, otherwise known as maxipime. This one is a really good broad spectrum empiric coverage kind of antibiotic. It has really good gram-negative coverage. It has anti-pseudomonal activity, which is really good for it. Again, like I said, note drugs that are having anti-pseudomonal activity. And it still has good gram-positive coverage. Now again, it doesn't cover MRSA, and like all other cephalosporins, it does not cover Enterococcus. So you typically do not see, and plus it has no anaerobic coverage, so this is not really good for abdominal infections. It's not good for that. But it is really good for things like neutropenic fever. We're worried about patients who who have, say, recently received chemo, and they're neutropenic, or if they have other immunocompromisation, this may be a good broad spectrum drug for them. And you see it used a lot for nosocomial pneumonias, either hospital-acquired pneumonia or ventilator-acquired pneumonia, so that stands for. And then again, if you're suspecting pseudomonal infections, this is a good drug to go with, right? So cefepime is a good broad spectrum antibiotic, but again, a lot of times, so say if I have a patient who's coming in, and I know they're a HEMONC patient who's recently received chemo, I'm more likely to give them cefepime. If they're not, they're relatively otherwise healthy, and I'm not worried about Pseudomonas, then I would give them ceftriaxone instead, right? I want to use a more narrow spectrum drug if I can to avoid that emergence of resistance. Okay. And so if I were to say I had a patient who I was worried about, they had a ruptured appendicitis, and I were to give you the choice between something like Penicillin, tazobactam, and cefepime, which one would you choose?
Cefepime is more broad spectrum.
You choose cefepime? Yeah.
Or what, say that again.
So if I had a patient came in and they had a ruptured appendicitis, which antibiotic would I want to give them? Would I give them cefepime?
Oh, no Enterococcus, you give them the Penicillin.
Right, so the way your mind should be thinking is, okay, coming in for an intra-abdominal infection, what kind of bugs am I treating? Thinking gram-negative, anaerobes. Okay, what drug is going to cover that? Penicillin, tazobactam. Yeah, that does have good Enterococcus coverage, has good pseudomonal coverage. Cephalosporins, not going to cover it, right? Because this one doesn't have an anaerobic coverage. It's not going to cover Enterococcus. That's a better option to go with. Or the pip-tazo is going to be the better option to go with, right? So that should be your mindset when you see a test question that comes up like that. Patient comes in with this, what's the most likely antibiotic going to be to treat their infection? And it all goes back to these little stop signs, right? And then knowing things like Pseudomonas coverage, MRSA coverage. That makes sense for everyone so far? Okay. Some of the newer, there's a newer generation of cephalosporins. This one I have not seen used all that too often in clinical practice, but still, new drugs are expensive drugs, and so I haven't seen it used all that too much. There's ceftaroline, otherwise known as Teflaro. This one's really interesting because it has good gram-negative coverage, good gram-positive coverage, still no Enterococcus, but it actually covers MRSA. So if you were worried about MRSA, this might be a decent agent to go with. Still has anti-pseudomonal activity and does not have any anaerobic activity. So this might be a good option if you're worried about like a patient who might be at risk for MRSA and Pseudomonas. This would be a good option to go with. And the indications for it so far are for community-acquired pneumonia and also skin and soft tissue infections. But note, this one also has to be renally adjusted. So really, ceftriaxone is the only one you don't really have to worry about that with. Another one that has been recently released is going to be the ceftolozane and tazobactam. This is another combination with the beta-lactamase inhibitor, where this one doesn't have any MRSA coverage, but still has pretty good gram-negative and gram-positive coverage. Has good anti-pseudomonal coverage, and this one actually induces some anaerobic coverage as well. So this will actually cover your Bacteroides. So this one might be a little bit better option for intra-abdominal, but you still miss that Enterococcus coverage. So who knows? The reason, the way the indications got put on by the FDA is you'll see that it actually is indicated for complicated intra-abdominal infections, but it's in addition to another drug, metronidazole or Flagyl, which we'll talk about a little bit later. So keep in mind that that indication is there, but you have to use it with the other drug to get that full coverage that you're looking for. And then it could also be used potentially for complicated urinary tract infections. Okay, so I'm going to go ahead and cut it here for now. I think you guys probably had enough antibiotics to have your fill for the year, but guess what? We got a whole another lecture on it. Any questions in the meantime? Yes?
So I'm looking on this list of top drugs. I see like 12 or 13 antibiotics on
Uh-huh.
there. So should we just know those for sure, or do we know all these as well?
You should be aware of all of these. Yeah, sorry. So the thing is, those are outpatient prescriptions, right? So a lot of the drugs we're talking about, especially the IV ones, you're only going to see on the inpatient side. That's not going to be captured on that list, right?
Oh, I got
So
you.
those are outpatient prescriptions that were filled in the U.S.
Send them on their way. Okay.
Yep. Any other questions? Yes. Shh, guys.
You had a chart in your slides, like early on, where it has like the flow chart.
Yep.
So if there's like specific ones on there that weren't mentioned further in your other slides.
Just focus on the ones I'm mentioning here in these sections.
Okay.
Yep. Yeah. Anything else? All right, guys, stay dry.